So I'll be talking about how to choose the right antibiotic based on microbiology and pharmacology in GI infection. So this is what the topic is. So I'll be talking about very basics of antibiotic selection in the most common GI infections that we face. So acute diarrhea, cholangitis, cholecystitis, pancreatitis, spontaneous bacterial peritonitis. So I begin with a case, 30-year male immunocompetent with a history of 2 days of diarrhea, 7 to 8 times per day, no fever, no blood in stools, able to function, but with change in activities. There is a history of travel. On examination, there is no positive finding. So what antibiotics for how long? So does the patient need antibiotics? Yes or no? Raise your hands. Yes. None. Okay. No antibiotics. Raise your hands, please. Okay. Some are with neither. Anyway, so if we talk of acute diarrhea, primarily it can be viral, which is rotavirus, calcivirus, astrovirus, enterovirus. If we talk of bacteria, it can be Salmonella, Campylobacter, Shigella, E. coli, Clostridium difficile. Parasitic can be Giardia and Cryptosporidium. So some salient features about acute diarrhea which one needs to know are, one is most episodes are self-limiting. Toxin-related gastroenteritis, which is primarily staph and bacillus, that is, they induce diarrhea by releasing toxins. You do not need antibiotics. Empirical antibiotics primarily are not indicated. Probiotics, prebiotics, again, like VSL-3, are not recommended for acute diarrheas. In Salmonella, antibiotics administration may in fact prolong the shedding in stool. Antibiotic sensitivity and testing with acute diarrheal infection is currently not recommended. And stool diagnostic studies done, if available, in case of dysentery. What is dysentery? It is macroscopically visible blood in the stool, or moderate to severe disease and symptoms lasting for greater than 7 days. Antibiotics are indicated and should be given if stool culture shows the organism. However, empirical antibiotics may be considered in situation with fever, blood or pus in the stool, immunocompromised patients, neonates, elderly, Salmonella bacteremia, cholera, traveler's diarrhea, where you have presence of fever. Here in traveler's diarrhea, you can give loperamide, which is considered to be safe, which decreases the duration of infection, and pathogens are noted in 50 to 94% of the patients with traveler's diarrhea, and that's the reason you resort to antibiotics, especially azithromycin, which is the treatment of choice here. So I hope you can see that. If you can't see, I'll just tell you, if you get an organism, Campylobacter, treatment of choice is azithromycin. Clostridium difficile, if you're getting in the stool, treatment of choice is vancomycin oral and not metronidazole. Non-typhoidal Salmonella, usually you don't need antibiotics. Salmonella typhi, drug of choice is ceftriaxone. Shigella, again, drug of choice is azithromycin or ciprofloxacin. Vibrio cholerae, treatment is doxycycline. And non-Vibrio cholerae, usually you don't need antibiotics. Yersinia, again, treatment of choice is trimethoprim sulfamethoxazole. Cryptosporidium, treatment is nitazoxanide. Cyclospora, again, trimethoprim sulfamethoxazole. Giardia, you need to give tinidazole. Cystisoisospora, trimethoprim sulfamethoxazole. Trichinella, albendazole. Unfortunately, you need to remember this as the treatment of choice based on the organism that you are getting in stool. Once you have decided to give antibiotic, you need to give an appropriate antibiotic for appropriate timing. So usually what is done is for levofloxacin, you give a single dose. If the diarrhea still continue, you may choose to give a 3-day course. So nowhere in these you will find the duration of therapy more than 3 days. So whether either it is a single dose for a single day or it's a 3-day course, not more than that. So please remember this. For acute diarrhea, you're giving this only for a period of around 1 or 3 days. Azithromycin is primarily for fluoroquinolone-resistant Campylobacter and preferred for dysentery or febrile diarrhea. Rifaximin, which is now one of the commonly used drugs that we use, do not use if suspicion of Campylobacter, Salmonella, or Shigella. It is not effective in these scenarios. So again, as I have highlighted, either a single dose or a 3-day course is the one that you require. So this again is a busy slide, again, American Journal of Gastroenterology 2016, which talks about management of diarrhea. This is what we have the last. So here, importantly, you need to remember acute diarrhea, initial management is oral fluid therapy. If you have watery diarrhea with a moderate to severe illness, and if it's travel associated, you need to give antibiotics. However, they have defined here moderate to severe illness, which you need to remember. So moderate severe illness is total disability due to diarrhea. Patient is unable to get up. Moderate is able to function, but with post change in activities due to illness. This is defined as moderate diarrhea. Mild, that is no change in activities. This is what the mild diarrhea is. So if it's travel associated, you need to give antibiotics. If you have a non-travel associated moderate to severe illness with high grade fever, you need to give antibiotics for a duration of more than 72 hours. Again, if you have dysentery, as I mentioned, dysentery is passage of blood along with stools, which are macroscopically visible. Here in this setting, if you have severe illness with fever more than 101, and this is travel associated, again, you need to give antibiotics here. And as I mentioned earlier, treatment here is azithromycin, which is usually 500 milligram once a day for a total period of 3 days. So coming back to our case, so 30 male, as I mentioned, immunocompetent. What do you think now? Should we give antibiotic in this particular case? I hope you are listening to what I'm telling. Yes or no? Please raise your hands. Yes. So only 4 people were possibly listening to what I was telling, possibly. Anyways, so the reason why I have mentioned that azithromycin may be required for 3 days is this. As I mentioned, the moderate disease is patient is required to change his daily activity. So you don't have fever, you don't have blood in the stools, still the patient is a bit debilitated. And that's the reason why you need to choose antibiotics here, which is for a period of 3 days alone. However, if there is no history of travel, that it is not traveler's diarrhea, then you can get away only by giving loperamide. So just a word about loperamide is a very good drug to bring down the frequency of stools dramatically. Should be avoided in elderly patients, should be avoided in children, should be avoided when you have fever or blood in stools. If you tell me, we keep on getting calls, we are having severe diarrhea, 20 stool frequency, watery stool, no blood, no fever, give them loperamide, patient will be very happy. So it reduces stool frequency significantly. And in this particular group, you just need to avoid it, the group that I have just mentioned. Okay. So coming to a second case scenario, 40 male, pain in abdomen for 10 days, fever for 2 days, jaundice for 2 days. On examination, you have icterus, pulse rate of 100, temperature of 100, respiratory rate of 18 with a normal blood pressure, a normal TLC with a bilirubin of around 3. Ultrasound shows a gallbladder stone with a dilated bile duct with 1.2 centimeter stone in the bile duct, that is choledocholithiasis, and diagnosis is GB stone with CVD stone with cholangitis. Does he need antibiotics? Okay. So I think it's quite obvious in the scenario when I have said that it's cholangitis. Obviously, you have to give antibiotics in this patient. The question can be what. So if you see the microorganism in acute cholangitis, again, this all will depend upon the individual centers. You may not have this uniformly present in each and every center, but this is what the commonly cultured organism in patients with acute cholangitis is predominantly gram-negative bacilli. E. coli, Klebsiella, Pseudomonas constitutes the majority of the organism. Gram-positive predominantly is Enterococcus and Strepto. Then you have anaerobic significantly to the tune of around 14 to 20%. This is very, very important to remember because your antibiotics are tailored to the specific organism that you usually give. Once you don't have the culture report, then for starting empirical antibiotics, you need to know what organisms are usually found. So E. coli, Klebsiella, Pseudomonas found most commonly. Antimicrobial activity against positive bacteria. Severity of cholangitis, you need to know. Renal and hepatic disease, you need to know. Past history of antimicrobial administration. Obviously, if the patient has received a prior antibiotic outside, you don't want to continue with the same antibiotic. So taking an appropriate history of antibiotic intake is very, very important. Local epidemiology and susceptibility data, you should be knowing in your hospital, what are the organisms most commonly cultured. Biliary penetration of antimicrobial agent, again, very, very important to remember. History of allergies and other adverse events to antimicrobials, pharmacokinetics, pharmacodynamics, and toxicity. So these are the factors that you need to know to choose an appropriate antibiotic. Very, very important. Timing, again, for septic shock, you need to administer antibiotics immediately. For others, you may take around less than 6 hours. Duration is 5 to 7 days. If gram-positive cocci, Enterococcus, Streptococcus, usually it is prolonged antibiotics for a period of 2 weeks. If the obstruction persists, that is, you have a CBD stone in the bile duct, you haven't received it, removed it, then you need to continue the treatment for long. And if there is abscess or the cholangitic abscess, what we say in the setting of CBD stone, then you need to continue the treatment till the resolution of this particular abscess in the liver. So if we talk of antimicrobials with good biliary penetration, you need to know all cephalosporin, first generation, second generation, third and fourth generation have good biliary penetration. Among fluoroquinolones, ciprofloxacin, pacifloxacin have a good penetration. Aztreonam and clindamycin again have a good biliary penetration. Sorry, I think this is some problem with the laptop that I am using, because initially on my Mac it was okay. Anyways, so we'll skip that. So once we talk of cholangitis, what you need to remember is, as I showed you the patient, that patient was not having any organ failure. So if the patient is not having organ failure and a patient is of cholangitis, then we label this as grade 1. Grade 3 is primarily cholangitis with any organ failure, maybe cardiovascular, neurological, respiratory, renal dysfunction, hepatic dysfunction, you defined by prothrombin time greater than 1.5, or hematological dysfunction with a platelet count less than 1 lakh. So simple parameters, very, very important to decide upon the organ dysfunction. So if you have at least one of the organ dysfunction, say a patient of cholangitis with a prothrombin time of say 2, this patient has got grade 3 cholangitis. Grade 2, again, this is with any 2 of the following, which is TLC greater than 12,000 or less than 4,000, high fever, age greater than 75, bilirubin more than 5, or hypoalbuminemia. So this will define moderate cholangitis. For mild cholangitis, primarily you need to give antibiotics, finish the course of antibiotics. You may choose to delay a biliary drainage if you are not able to drain at that point of time. However, if it is a grade 3 cholangitis, then the patient merits an urgent biliary drainage. It should not be delayed, otherwise it causes a high mortality. So urgent biliary drainage, organ support, and antibiotics all need to be done at approximately the same time. Grade 2 cholangitis, antibiotics, and general supportive care, and then you resort to early drainage. So very, very important that if you have grade 3 cholangitis, patient merits an early biliary drainage. Biliary drainage can either be done endoscopically or a percutaneous biliary drainage, which is known as PTBD. So again, antimicrobials with high prevalence of resistance among Enterobacteriaceae, this you need to know. Penicillin, ampicillin, sulbactam, cefuroxime, these have got high resistance. Among fluoroquinolones, ciprofloxacin, levofloxacin have again got high resistance. So coming back to the patient, cholangitis, this patient has cholangitis. Obviously, he is grade 1 cholangitis. He definitely merits antibiotic. That is how There isn't any doubt about it, and he needs to continue antibiotics for a period of around 3 to 7 days. Obviously, you need to remove the stones in these particular cases. However, when you have grade 1 cholangitis, you may delay the biliary drainage. Similar to cholangitis, cholecystitis, antimicrobial should be administered to patients with acute cholecystitis, except for mild cases. Organism and antibiotic selection is the same as for cholangitis. Coming to pancreatitis, again, 45 male, chronic alcoholic, pain epigastrium 4 days, fever for 2 days, pulse rate of 120, that is tachycardia, fever, high TLC, that is 14,000, amylase is high, there is organ dysfunction, that is renal failure, and CT is showing 50% pancreatic necrosis with collection. So mind you, this patient is a young patient, fourth day of severe acute pancreatitis with necrosis more than 50%, with renal failure, that is organ failure. So in this particular scenario, does he need antibiotics? So does he need antibiotics? No antibiotics. No. Okay. So anyone with for yes? Yes. I do not see the percentage. Yes. Okay. Anyone for no? बीच वाले लोग भी क्या है आधे? Yes and no. Okay. So I'll just try to clarify then. That's good. So AGA, that is American Gastroenterology Association, suggests against prophylactic antibiotics. So what do they say? You should not be giving antibiotics for prophylaxis. Why? Because it has got no impact on single or multiple organ failure. It does not decrease organ failure, or it does not decrease the length of stay. However, antibiotics are indicated for extra pancreatic infection, that is cholangitis, UTI, and pneumonia. So if you tell me a patient has pancreatitis and you have cultured organism, say in the urine, or you have sputum which is positive for an organism, it's an extra pancreatic infection. This patient possibly merits antibiotics even early in the course. Infected necrosis, mind you, this is infected necrosis, should be considered in patient with pancreatic necrosis who fail to improve after 7 to 10 days of admission. So there are two things. One is necrosis, the other thing is infected necrosis. Okay. So in infected necrosis, either you do initial CT guided FNA for gram stain, which is rarely done, no one does that, or you give empirical antibiotics. If blood or culture turn out to be negative, you need to stop that. Okay. So what I'm talking of is infected necrosis. You have to prove infected necrosis, or there is a very high suspicion of infected necrosis. So in patients with infected necrosis, if we choose to give antibiotics, it has to be carbapenem, quinolone, metronidazole, and the thing that these antibiotics do is delays or avoid intervention in patients with pancreatitis, which is usually drainage with the percutaneous catheter or with endoscopic drainage. Routine antifungal again is not recommended. So what happens as the extent of necrosis increases, the chances of pancreatic infection increases significantly. So if you see less than 30% necrosis, the risk of pancreatic infection is around 22%. However, if you have more than 50% necrosis, the chance of infection is 46.5%. So very high if the necrosis increases. So extra pancreatic infection, antibiotics are indicated. There is a strong recommendation and moderate quality of evidence. Prophylaxis in severe pancreatitis, not indicated. Again, strong recommendation, moderate evidence. Prophylaxis in sterile necrosis, again, not indicated. Strong recommendation, moderate evidence. Infected necrosis, recommendation is you give antibiotics, it delays or avoid intervention. Again, quality of evidence is moderate. Routine antifungals should not be given. Again, if you talk of organisms that we get in patients with pancreatitis, usually monomicrobial, E. coli, Pseudomonas aeruginosa, Staph aureus, and Klebsiella form the majority of the organism in these particular group of patients. Antibiotics with good penetration include cephalosporin, quinolones, carbapenems, and metronidazole. So coming back to the patient, so what do you think? Antibiotics should be given or should not be? Okay, so just need to understand this patient is on day 4th of pancreatitis. Okay, so day 4 of pancreatitis with features of SIRS, that is systemic inflammatory response syndrome. This patient has features of those, though he has got a significant necrosis on the CT scan, yet you don't have convincing evidence to say that there is infected pancreatic necrosis, which usually happens after the first week. So we think of infected pancreatic necrosis usually after 7 to 10 days of admission. Very, very important to remember. And that's the reason you want to avoid antibiotics. Coming to the last part, that is spontaneous bacterial peritonitis, 45 male, alcoholic cirrhosis with ascites, pain epigastrium for 4 days, fever for 2 days. On examination, you have pulse rate of 100, 14,000 count with ascites showing 500 cells with 90% neutrophils, and diagnosis is alcoholic cirrhosis with spontaneous bacterial peritonitis. So does it need antibiotics? Okay, I think this is very clear from this slide. Once you say that there is spontaneous bacterial peritonitis, then usually these patients will merit antibiotics. What I want to show you here is the organism. E. coli, Klebsiella, Pneumococcus, Streptococcus form the majority of the organism, which is usually monomicrobial, and polymicrobial is very, very rare in this particular scenario of spontaneous bacterial peritonitis. This is one of the recent guidelines, European Association of the Study of Liver, which says that if you have spontaneous bacterial peritonitis and it is community acquired, then you resort to a 3rd generation cephalosporin or a piperacillin tazobactam group. If it's in healthcare associated spontaneous bacterial peritonitis, you choose organisms which have nosocomial infections if high prevalence of MDRO or sepsis. Again, if there's a nosocomial infection, you resort to carbapenem to begin with. So very, very important to remember. And the duration is usually 5 days. So this patient, obviously, he needs antibiotics. And the most commonly used antibiotic for spontaneous bacterial peritonitis is the 3rd generation cephalosporin, that is ceftriaxone, which we commonly use. If somehow the patient is resistant or received earlier, then we resort to piperacillin tazobactam. This is what in day-to-day scenarios that we do. So to summarize, most acute diarrheal episodes are self-limiting, no antibiotics. Empirical antibiotics, specific situations after the stool culture. Acute cholangitis and cholecystitis do need antibiotics. There is no role of prophylactic antibiotics in severe acute pancreatitis. And spontaneous bacterial peritonitis is usually monomicrobial, and a 3rd generation cephalosporin usually does the job.